but usually in the range of 30 to 40% or a little below 40%, all you see is just edema and crackles. So these are the physical exam findings and symptoms. So remember these three: classic dyspnea, orthopnea, and PND, and then some fatigue and swelling. When you have these present with presence of some risk factors, then you must think about heart failure. And the diagnostic test or the lab test to do would be, one thing to do would be BNP. Again, BNP is another screening test, so it's a brain natriuretic peptide. If it is high, then yeah, your patient may have heart failure. But if it is low, then you can basically rule out heart failure in some cases. For example, just like D-dimer, this should not be low if the patient has heart failure. So if it is, the number is less than 100, then you can usually effectively say the patient does not have at least acute exacerbation of heart failure. If the number is much higher than 500, then definitely it's a sign of heart failure. So it's more of a prognostic test. If your patient has a baseline BNP that you drew at some point in the past, and now they come in with symptoms and the BNP is much higher than their baseline, then also you can say, okay, my patient has acute exacerbation of heart failure. But a single number of lower than 100 will effectively rule out heart failure. The diagnostic test of choice would be echocardiogram, so that will show ejection fraction. So again, like lower than 40 would be sign of heart failure. A patient may also need some EKG and troponins while you're waiting for the echo, and these will show if there is any leakage because of the troponin leakage because of the failure, or if there is any ST changes. So these can be non-specific ST changes, but usually they don't develop these unless they have concomitant ischemia going on as well. And remember that number one cause of acute exacerbation of heart failure is cardiac ischemia. So that is why, for that reason, this troponin may be a little bit high. So this is now breakdown of heart failure into two different categories. So heart failure is just a general term, very layman term, so we need to be more specific. So we call it either heart failure with reduced ejection fraction, which means that there is systolic dysfunction, or heart failure with preserved ejection fraction, which means there is diastolic dysfunction. So these two are very distinct from each other. You can see reduced ejection fraction or systolic dysfunction is in a way easy to identify and diagnose, because you can clearly see that there is systolic dysfunction, ejection fraction is lower than 40%, and you say, okay, my patient maybe has heart failure, and classic symptoms and signs. On the other hand, heart failure with preserved ejection fraction usually has a normal ejection fraction, and this is becoming more and more common these days in general population, so it's very important to recognize it. So even if the ejection fraction is normal, you will see that on the exam there is some diastolic dysfunction, and that counts as heart failure with preserved ejection fraction. So these patients also present with symptoms, but they are usually different from systolic, and we'll talk about the risk factors that go into both of these individually. So let's look at the two categories. So generally speaking, in old times, or I guess long time ago, systolic dysfunction or this category was considered to be left-sided failure, and diastolic dysfunction was considered to be right-sided failure. But now we are not using this terminology anymore. We just stick with systolic or this, and diastolic or preserved ejection fraction. Anyhow, there causes, so the underlying causes or underlying etiology of these two categories is very similar. So there are three main underlying etiologies. So remember, these are etiologies and these are categories. So underlying etiologies are hypertrophic cardiomyopathy, dilated cardiomyopathy, and restrictive cardiomyopathy. So these are cardiomyopathies and these are failures. So cardiomyopathies don't always give rise to systolic dysfunction or diastolic dysfunction or heart failure. They are pathologies. They are going to be present before the onset of symptoms and signs in the disease process. They are going to be underlying mechanisms, and there are risk factors for each one of these three individually also. So to complicate things further, hypertrophic cardiomyopathy has these risk factors or underlying causes attached to it. So what kind of patients get hypertrophic cardiomyopathy? Well, patients with long-standing hypertension can get it. Hypertrophic obstructive cardiomyopathy patients can get it. So these are your relatively young patients with HUCM, they can get it. Septal hypertrophy patients, so patients usually who have hooked, they have accompanying septal hypertrophy, they can get hypertrophic cardiomyopathy. And then aortic stenosis patients can get concentric left ventricular hypertrophy. So basically all these patients, what happens is their myocardium becomes very hypertrophic because they are trying to compensate for extra demand, and that's how they become hypertrophic. And these are the risk factors for it. And so these are the risk factors. This becomes the underlying etiology, and this becomes the final phenomena. One of the more common etiologies is dilated cardiomyopathy. So this is the most common among all these three. So what happens with dilated cardiomyopathy? So these are the risk factors for myocardium to become dilated and therefore cause failure. So what are the risk factors? You can see these are very common regular things that happen in general population. So coronary artery ischemia can eventually cause dilated cardiomyopathy. Infections can cause acute dilatation of the myocardium, for example myocarditis and endocarditis. And you remember from your from our DSA in fever that these two things can develop complications in the form of heart failure. So this is how this happens. When there is infection, it can cause dilatation of the myocardium, and usually this is an acute picture, and these people don't have usually other risk factors, especially with myocarditis, and they are relatively younger patients, and this also is more reversible. Then you have your valve regurgitation patients, so patients who have valvular regurgitation, for example severe AR, severe MR. What happens is they have a lot of extra blood circulating because there is a double dip of the blood. So these patients continue to dilate their myocardium to compensate for or to accommodate for that extra blood, and that's how they develop failure. So dilated cardiomyopathy patients will develop first left-sided failure, systolic dysfunction, and then also overall heart failure. And then lastly, your very big risk factors, the most common risk factor is diabetes. So diabetic patients unfortunately continue on to develop dilated cardiomyopathy, not only just because of the direct effect of diabetes, but also because of small vessel ischemia. So they develop small vessel ischemia and dilated cardiomyopathy. Thyroid disorder, for example hyperthyroidism, usually Graves' disease, can cause dilated cardiomyopathy. And lastly, there are drugs that can cause dilated cardiomyopathy. For example doxorubicin or some chemotherapy drugs can cause this. So this is all just to keep in mind. So of course whenever we are taking history from the patient, we should ask about these risk factors, or we should look for these risk factors, and whenever they are present, we should suspect either one of these underlying mechanisms and which is resulting in one of these two failures. Then there is restrictive cardiomyopathy. So restrictive cardiomyopathy is relatively uncommon, but then there are risk factors for this too. So infiltrative disorders, for example lupus, amyloidosis. So these patients have connective tissue disorders. They already have an underlying disease, or they present with heart failure because now the disease process has led to this, but they never showed with these diseases before. So it can be any presentation. Anyhow, they have these infiltrative disorders that can cause a restrictive cardiomyopathy, and then they move on to develop. Usually they start with diastolic dysfunction and then failure with preserved ejection fraction. Pericardial disease patients, so usually there are lots of causes of pericardial disease. So starting from acute pericarditis, patients post MI, patients can develop Dressler syndrome. Patients with uremia, like chronic renal failure patients, can get uremic pericarditis and develop this pericardial disease. Patients with radiation therapy or chemotherapy can get this. So there are many other causes of pericardial disease that can lead to restrictive cardiomyopathy. So these are the risk factors. Now among these three categories, what are the risk factors? Pretty much all of these pretty much all of these and the ones in these two boxes will cause systolic dysfunction first and reduced ejection fraction, except that hypertensive cardiomyopathy can cause both systolic dysfunction and diastolic dysfunction. And then all the restrictive cardiomyopathy patients usually start with diastolic dysfunction and then eventually can develop systolic dysfunction. So remember, the number one cause of systolic dysfunction is diastolic dysfunction. So they start out with preserved ejection fraction and then eventually develop a global systolic dysfunction. So that's how this phenomena works. And of course, in the setting of all those symptoms that we talked about in the previous slide, We just look for all these key features and findings and clues in the history and physical exam to see if our patient has any of these present. Individually speaking, additional symptoms and signs, of course, so we're not done yet. So these are your hypertensive cardiomyopathy patients who have all these risk factors present. They developed hypertensive cardiomyopathy. What additional symptoms they should have? So you can see we can link it to these either diagnoses or disorders or risk factors. So for example, because we know they can have a history of aortic stenosis, now they have either long-standing hypertension, syncope, exertional chest pain because of stenosis. They may have end organ effect from the long-standing hypertension, so they can have any of these present. And of course then we'll say, okay, there are some signs too, so they may have elevated hypertension because of course we know they have hypertension. They have some signs of end organ effect from hypertension, which you already know what those signs are. They may actually have a systolic murmur that increases in intensity with Valsalva or staining. So you already know that that is the murmur of Hookham. They may have parasternal heave because of hypertrophy, septal hypertrophy, or they may have ejection systolic murmur because of in the aortic area because of aortic stenosis. So if you have these are additional clues in addition to the symptoms of heart failure, like all the dyspnea, orthopnea, and PND and swelling. They may have these additional symptoms and these additional signs. So this is how you finally solve the puzzle. Next is the dilated cardiomyopathy patient. So these are the risk factors we just talked about. So these, the biggest is ischemia, then they can have myocarditis, endocarditis, regurgitation, diabetes, thyroid drugs. So they, in addition to the symptoms we just talked about that were just the common symptoms, their additional clues in the history would be they have a history of MI or angina or recent travel causing myocarditis. They have a recent diagnosis of a valve disease that is causing valvular regurgitation. They just had have a history of diabetes or history of thyroid disease, or they just used some chemotherapy for cancer like doxorubicin. Additional signs would be they have a murmur of aortic regurgitation. So for example, if a patient has valvular problem, so that is causing heart failure, you will hear a diastolic murmur of AR. In the case of mitral regurgitation, you will hear a pansystolic murmur in the mitral area. Then you may actually hear some crackles, which is just a general sign of heart failure anyway. You may see some sign of end organ damage from diabetes. So you already know your patient has a pretty full-fledged diabetes and now are coming in with symptoms and signs of heart failure. So of course, why not? This is probably diabetes causing dilated cardiomyopathy, and they may or may not have signs and symptoms of hyper or hypothyroidism or a history of hypo or hyperthyroidism. So this is how we get to the bottom of this. And the last one category was restrictive cardiomyopathy. So of course, these are the risk factors or causes of that. And additional symptoms or clues from the history would be they have a history of lupus or rheumatoid arthritis, pericardial disease, and then they have relevant signs of the pertinent diseases. So I'm not going to go into the detail of these diseases, but if you have any clues in the history for these diseases, you can definitely think about restrictive cardiomyopathy causing diastolic dysfunction and heart failure with preserved ejection fraction. All right, so that was all about the pathophysiology and underlying mechanisms and clinical picture of heart failure. So now we have classification. So New York Heart Association functional classification is most commonly used, most popular because it's New Yorker. So but anyway, so there are class 1 through 4. So class 1 is there is no limitation of any physical activity. People can do anything, anytime. Again, this is I don't know why they still have class 1 here. Anyway, there is no limitation of any physical activity, and they just continue to move on. But then class 2 is when they have slight limitation of physical activity. They're comfortable at rest, but ordinary physical activity can result in symptoms of heart failure. So they have mild symptoms at exertion. These people have marked limitation, so they have maximum symptoms at minimal exertion. And then class 4 patients have severe limitation of activity, so they have severe symptoms even at rest, or even when they are resting, they have symptoms of heart failure or they are dyspneic. So these are the patients who are sleeping in their chairs. Then there is labs and tests. So whenever, generally speaking, whenever you're suspecting diastolic or systolic dysfunction and you think that your patient has symptoms because of that, then these are the tests you will order. We already talked about BNP. So in addition to all those tests, the echocardiogram, the BNP, and chest x-ray, we can do complete metabolic panel. It's extremely important to draw this lab also because it can give you indirect clues. For example, your sodium may be low, so hyponatremia is one of the causes of hyponatremia is heart failure. Creatinine may be high, which may be causing heart failure, may be putting the patient at risk for heart failure if the kidneys are not functioning right, or it can be vice versa. Heart failure can cause renal dysfunction. And then, of course, if patient has high glucose and they have not been diagnosed with diabetes before, now you can say, all right, well, I know what's causing your heart failure. It's probably uncontrolled diabetes. Thyroid, of course, naturally will need to be drawn. And then you can also do angiogram to see if there is a lot of ischemia, coronary artery disease that's causing heart failure. And then these tests, which are not as common, of course, but lupus or rheumatoid factor can also be tested. Lastly, if nothing is making sense and you just need to figure out what's causing heart failure in your patient, and you are thinking that it may be an infiltrative disorder, but you just quite can't get the diagnostic clues, you can do endomyocardial biopsy to get the definitive answer. But this is rarely needed. Most of the time we get the answer by doing the basic labs and tests. This is a normal size heart, and you can see abnormally large heart. So this is a big heart, cardiomegaly. The cardiac shadow basically occupies more than 50% of the chest, so that's how we know this patient has heart failure. So this is an echocardiogram. So you can see cardiac shadow is too large, myocardium is too thin, and you know for sure this when you see this in motion, you'll see that this is not moving. It's hardly moving at all. So we call this global hypokinesia, and we know that this is dilated cardiomyopathy. So this was all about heart failure.